Our next speaker is Dr. Savino. Be talking about optical coherence tomography in neuro ophthalmology.
I'm not going to talk about the technology of OCT or how to read OCTs necessarily. What I want to do in the next few minutes is to tell you where I'm using various types of retinal and optic disc imaging in the clinical practice of neuro ophthalmology. And I'd be interested to hear from the other neuro ophthalmologists where they are using it. Most of what neuro ophthalmologists are interested in is the retinal nerve fiber layer. And this is so obvious that we tend to forget that the retinal nerve fiber layer, actually seeing the retinal nerve fiber layer, was not something that happened very long ago. I remember when I was a fellow in Miami, Dr. Hoyt came down to one of the meetings in Key Biscayne in Miami and showed his work on the retinal nerve fiber layer utilizing red-free photography, and showed us how it corresponded with visual fields. And it was a great revelation to all of us, and then we started to look and we started to see. So as many things that Bill Hoyt did, it was a seminal paper. However, one of the things that one of the more senior neuro-ophthalmologists told me once, and it's true, is if you think you have discovered something new, go read the old German literature, because it's probably there. And in fact, in a 1921 edition of the German literature, there was an article by Professor Alfred Vogt that described the ophthalmoscopic appearance of the retinal nerve fiber layer. And since Bill Hoyt was able to read the German literature, he did reference this in his paper. And one of the plates that Dr. Vogt had, Professor Vogt had, for some reason neither of these pointers are working. There you go. Showed a variety of retinal nerve fiber layers. These were normal here, and this was a completely absent nerve fiber layer here, but the superior arcuate bundle was intact. And this was another picture of a fundus where the entire retinal nerve fiber layer was gone, and he attached different diagnoses to these fundus pictures, so that just using a handheld monocular ophthalmoscope, he was able to describe the pattern of the retinal nerve fiber layer in 1921 and correlate it with various diseases. Now, it was left to the companies to come up with ways to turn this very simple way of determining things into a very expensive way of looking at the same things and making nice printouts. And these were the three machines that became popular in the United States. There was the HRT, the GDX, and the OCT, measuring various things. The Heidelberg was mainly used by the glaucomatologists because it was optic cup oriented. The OCT, the retina people latched onto this because it was better for the retinal nerve fiber layer than it was for the optic cup. These are second and third generation machines, and they all sort of measure each thing. So now you have the ability essentially to buy one machine and be able to look at the optic cup and the retinal nerve fiber layer. So how do we use this? Is it just a fancy way of depicting what Vogt told us in 1921 that you can see with an ophthalmoscope, or a red-free photograph, or is it predictive of something? And I'm just going to show you quickly 4 different areas in neuro-ophthalmology where we see a lot of patients: ischemic optic neuropathy, papilledema, MS, and chiasmal syndromes. Now, This was a study that one of my ex-fellows and I did using scanning laser polarimetry and non-autolytic ischemic optic neuropathy. And this was a typical patient who had an ischemic optic neuropathy some time ago, had a visual field defect here, and as you can see, the superior bundle is missing. And when you go down to the T-SNP curve, you find here that is missing and corresponds exactly to the visual field defect. But you didn't need this machine to tell you that. You had the visual field, and if you looked in, you actually saw that the superior bundle was missing. So, most people think that the OCT is superior to scanning laser polarimetry in looking for visual field changes and correlating them. But the imaging process is really, I haven't found it to be helpful in predicting visual outcome. In other words, if someone has an acute ischemic optic neuropathy, I don't even do these images anymore because it won't tell me if it's going to progress, it won't tell me if they're going to get better, etc. And I think it just mirrors the visual field loss after the disc swelling has gone down, so I don't even use this in ischemic optic neuropathy anymore. What about in telling the difference between papilledema and pseudopapilledema? You know, we talked about using fluorescein angiography. In some of the cases, it's very difficult to tell the difference. So if you could use these machines, and they could tell you the difference if the retinal nerve fiber layer is really thickened, that would help you. This is a patient who has bilateral disc elevation, and this is a patient who actually has buried drusen in the optic nerve. So what happens if you do a second-generation OCT on this patient or imaging? What you see is you see the drusen that are buried. However, I haven't found that this is much more useful than this in telling the difference between early papilledema. If this was, as Dr. Chavez said, a patient who had drusen and a little bit of retinal nerve fiber layer edema, I don't think the machines are good enough at this juncture to tell the difference. So I've been using this or ultrasound just to see if there are buried drusen. And this is the same patient on a different machine, and you notice that the T-SNP is a bit elevated, but if this patient had very early papilledema, they would look the same way. So I don't think this helps you at all. So in 2005, Tommy Hedges wrote an article in BJO and said that OCT is not helpful in distinguishing between papilledema and pseudopapilledema, and I think that's still correct. Excuse me. Now, one of Dr. Hoyt's fellows was Lars Friesen from Sweden. Now, when Dr. Hoyt did his original nerve fiber layer description with red-free photography, he did it by going to the glaucoma clinic. And he correlated the visual field defects in the glaucoma patients with what he saw on red-free photography. And Lars was a Neuro ophthlmology fellow. He really didn't care about glaucoma. So he did a similar sort of study in very few patients in a Neuro ophthalmology clinic, and he took a couple of people with optic neuritis, and this is the pictures from those publications. Here they would do these painstakingly in focus, red-free retinal photography, and they would correlate these troughs where they're more black, where the retinal nerve fiber layer is missing, and they did static perimetry using a Tübingen type machine, and were able to correlate these defects to visual field defects on the perimeter. So much so that this was true that for many years in the late 70s and the early 80s, evaluation of the retinal nerve fiber layer, even for glaucoma specialists, became what was described by Harry Quigley as the gold standard of evaluating glaucoma. Not the optic cup, but the retinal nerve fiber layer. One of the things I find fascinating about this article, and remember, this article was back in I don't remember exactly when it was, the late 60s, I think. Larry's one of the smartest people I know. And he only had 2 patients with MS, and he demonstrated retinal neurofibrillary defects. And the last sentence of his paper, or last paragraph, he said, these defects attest to the insidious attrition of axons in MS. And this was at a time when we were all being taught that axons were not affected in MS. It was the myelin. And since there's no myelin in the fundus ordinarily, when you saw a dropout of axons in the MS patients, it meant that MS was affecting axons. And it took many years, almost a quarter of a century later, for the seminal article by Trapp in the New England Journal of Medicine to show that axons were, in fact, destroyed in multiple sclerosis. It was not just a process of demyelination. What has become very interesting is that, as I mentioned the other day, the pharmaceutical companies are looking to see if OCT can be a biomarker for the efficacy of their drugs. In other words, they can do MRI scans or see if there are new lesions, et cetera, but it's a lot easier and a lot less expensive for them to do OCT scans than MRI scans. And if they see a slow attrition of the retinal neurofibrillary without their drug and a better preservation with their drug, they can use that as a biomarker. And as I said, there are conflicting papers in different journals indicating whether or not OCT will be useful for that, so the answer is not in on that. Finally, the last thing I want to talk to you about is something that Dr. Chavez talked to you about, and it's compressive lesions around the chiasm. When we used to see these, we used to send the patient off to the neurosurgeon, but before we sent the patient off, we used to say, if we don't take this out, you're going to go blind. So, of course, the next question was, well, if you do take it out, am I going to get my vision back? And we would say, you know, that's not the reason we're doing the surgery. We're doing the surgery to prevent you from getting worse. Whether you get any vision back is unpredictable, and if you do, that's just a bonus. And we could not tell them anything different. And here's a patient that patient with the craniopharyngioma has junction scotoma, dense central scotoma in one eye, a temporal hemianopic defect in the other eye, and here's the OCT. Now, if the colors here are correct, if you can see this screen, you'll see that up here is all in the green, is all green, and the T-SNP curve is well within the normal range. That's with that dense visual field defect in both eyes. And so the patient had surgery. Here's pre-op, and here's the post-op visual field. Visual fields, because the OCT was normal, the visual fields came back to normal. And we did a series of these patients and published the results in Investigative Ophthalmology in 2008. And what we essentially found, if preoperatively the retinal neurofiber layer is less than 80 in thickness, the chances of getting any recovery of vision is practically zero. And the better the thickness in the retinal neurofiber layer, the better you're going to have recovery independent of the mean deviation of the visual field defect. So, in conclusion, where am I using this technology in neuro ophthalmology? Retinal neurofiber layer imaging is at times descriptive, and you really don't need it unless you're going to a meeting and you want to show some pretty pictures, all right? But it at times can be predictive. And I use it on all patients, pre and post-op parachiasmal lesions, and it will probably continue to be helpful. And whether it works out in the multiple sclerosis story is still not sure. But we need to keep, just like functional MRI, we have to keep our eye on this technology because I think it will be more helpful to us in the future. Thank you.